very much, Fiona. I am very honored to speak at Cambridge Radiology Forum, and I would certainly much more like to be in Cambridge than at home, but Fiona was very kind in saying nice things about me. I was the first ESR president to organize Congress online. I thought I would be the only one, but it seems that there are 2 additional online congresses after mine. So this is really a strange time. Certainly, so thank you very much, Fiona, for inviting me. We are very well aware of significance of Cambridge on a world level and of your university, and this is really a great honor for me from a very small country and very small university. We have only 4 million people. This is the largest university in Croatia, but for UK standards, still everything here is very small. I picked up the topics of ultrasound because this is one of the biggest differences, I think, between UK radiology and radiology here. I had the opportunity to get some insight into the way radiology is practicing all over Europe over the last 10 or 11 years that I'm in leadership of ESR. And certainly, there are many things in radiology in UK that are so advanced, and we would like to take and copy in ESR. And here, especially, for instance, some things like clinical audit in radiology that is here not really well developed or appreciated or even understood. But one of the biggest differences is that ultrasound, first, we don't have sonographers. So our technicians, radiology technologists, are not educated as well as those in United Kingdom. I think you have much better educated technologists. And we don't have sonographers as a special type of radiographers. So basically, all ultrasound examinations are performed by doctors here. And this is so in, I would say, still most countries in Europe, especially in South and East, in Italy, also in Austria, in Hungary. Basically, we do ultrasound examinations ourselves. We have much more radiologists than in UK, thanks to the fact that in last 10 to 15 years, we were allowed to take many residents, and radiology is very popular. So we have much more candidates for radiology residency than surgeons now, which is very different as compared to situation 30 or 35 years ago when I was starting. So, but there are considerable differences. So I thought I did most of my career ultrasound and also interventional radiology, so vascular ultrasound and breast ultrasound. And also we did some research in sonoelastography. When it occurred, we had good luck, I would say, that we are a very strong ultrasound center. We have interdisciplinary referral center of our Ministry of Health for ultrasound in medicine, together with our gastroenterologists. And that's why I would like to speak about those 3 topics: sonoelastography of liver, of breast, and then vascular ultrasound in the era of CT angiography and MR angiography. And then I will talk about radiology in Croatia in between and maybe at the end, so that I emphasize some differences. So just few words for the beginning about principles of elastography. Maybe some of you are not so acquainted with it, but there are 2 basic types: strain elastography, which is qualitative elastography, where you need to use pressure of transducer to see what is the stiffness of the lesion. And usually in strain elastography, hard lesions are depicted in bluish or dark colors. And then there are also quantitative sonoelastography methods, most well-known and widely used, especially by gastroenterologists, is transient elastography of fibroscan to measure liver fibrosis. Then there is shear wave elastography, two types, point shear wave elastography and 2D shear wave elastography. Now we have also 3D shear wave elastography that has now taken over and is, I think, the best to use. So there are many sonoelastographic methods with many companies that produce this. Hitachi was the first to produce train elastography more than 15 years ago. We were fortunate to have this machine. And then quantitative elastography, which is shear wave elastography. One, as I said, transient elastography of FibroScan, then this point shear wave elastography based on acoustic radiation force impulse, and then real-time 2D shear wave elastography. That was initially, we were very fortunate here to have the first Explorer system of supersonic, which was French company, which was later sold to Hologic, so we could use it. And then we also have some GE equipment, Logic 10 and 9, and some others. So we were lucky to be involved in this from the beginning. Now, regarding transient elastography, you actually do not get ultrasound image of the liver, and the elastogram is not displayed in real time. So you just measure the level of fibrosis. It's not an imaging modality, and it's mostly not used by radiologists at all, but by gastroenterologists. We use point shear wave elastography, although we don't use it because elastogram is not displayed in real time, but there is presence of ultrasound image of liver. And then and you see here commercial names. There are several companies producing it. What we use is two-dimensional shear wave elastography, where you do have presence of ultrasound image of the liver, also of the breast, and you have elastogram displaced in real time. So how does it look? So transient elastography of FibroScan, there is no imaging. It's easy to use, quick, cheap, reproducible. It's validated with histology and many studies, but it's difficult in intermediate grades of fibrosis. Limiting factors are obesity and depth, and it's not possible if there is ascites, excessive ascites. There is only one region of interest, and you get values of elasticity in kilopascals only. Point shear wave technology, you need to know prior knowledge of ultrasound imaging and anatomy. You have ultrasound image of liver present, but elastogram is not displayed in real time. There is a fixed region of interest. You can use it with any body mass index, any depth up to 8 centimeters. You can do it through any intercostal space. It's reproducible, quick, relatively easy, and was validated with histology. And it's known that it's difficult in intermediate grades of fibrosis. We perform it with arm abducted. After 4 hours of fasting, patient should breathe slowly, and then we take at least 6 valid measurements of the right hepatic lobe, and you need to be at least 1 to 2 centimeters away from the liver surface and in area without vessels. So first studies in liver were done this way, but we now use almost exclusively this, which is 2D shear wave. This is shear wave with imaging, so there is, or you need much more ultrasound experience than with point shear wave elastography, but our gastroenterologists also became now very skilled with it. We have ultrasound image plus real-time elastogram. We need to know where to place region of interest and use several quality indicators like propagation maps and quality color maps. And this is now state-of-the-art and most clinically useful type of elastography for liver. However, different ultrasound systems give different shear wave elastography measurements, and the question is which type to use, and shall we use kilopascals or meters per second? Now, shear wave elastography measures the speed of shear waves in meters per second, which can be converted to kilopascal, giving an indirect measure of the elasticity of the tissue sampled. So what we measure is Young's modulus of elasticity that depends, of course, on density and square of shear wave velocity, and conversion of velocities in meters per second to kilopascals with the assumption that the density is 1 is easy. So FibroScan or transient elastography provides measurements only in kilopascals. Point shear wave used to only provide measurements in meters per second. And most clinical studies published to date are or were with transient elastography or virtual touch quantification point shear wave. It changed over last, I would say, 3 or 4 years. But what is a measurement of stiffness of liver in general useful for? We won't go into too many details, but these are basically 5 indications. Evaluate stage of fibrosis, evaluation of existence of clinically significant portal hypertension, evaluation of presence of risky esophageal varicosities, prediction of clinical outcome of chronic liver disease, and characterization of liver tumors. So just very briefly, a relation of liver stiffness and histopathology is that the higher the fibrosis stage by METAVIR is, the higher is the elasticity in kilopascals. Of course, there is some overlap in different grades. There is a failure to measure liver stiffness depending on the body weight. So those obese people with very high body mass indices over 40, you fail to perform, to measure liver stiffness in over 40% of patients. The thinner the patients are, more easier it is. Now, I would just briefly go through elastographic liver fibrosis stage assessment. Regarding transient elastography, these are these meta-analysis, different stages of fibrosis and cutoffs in kilopascals. We see that using different cutoffs, which are 7 or 15, basically sensitivities and specificities are around 0.8 or little higher. There is no difference in diagnostic confidence of elastography between hepatitis B virus and C for all METAVIR stages. And this scoring system assesses extent of inflammation and fibrosis by histopathological evaluation in a liver biopsy of patients with hepatitis C. This is a point shear wave virtual touch quantification, point shear wave elastography, again, meta-analysis with cutoffs in meters per second. As you see, again, area under the curve, so it's 0.8 to 0.9. Usually, what our gastroenterologist, Dr. Gugurevich, was one of the first to do these studies that were published in Ultrasound in Medicine, using these cutoffs of 1.3 for fibrosis, 0 or 1.86 meters per second for stages over 5. Basically, most clinical algorithms were based on FibroScan data, and it's easier to remember whole numbers when we look at cutoff values of normal versus cirrhosis. So it's usually 7 kilopascal and 15 kilopascal, or 1.5 meters per second or 2.2 meters per second. So, American Society of Radiologists in Ultrasound for hepatitis C, you see also here the cutoff values that are different for different point shear wave elastography systems by different vendors, and also 2D shear wave elastography for supersonic is 7 kilopascals and 15 kilopascals. And you see that this differs considerably compared to, for instance, MR elastography. So the message is that you know well which system you are using, and this is not comparable across different ultrasound systems. And just one thing for the end of liver, this is characterization of liver tumors with 2D shear wave elastography. There are some images and examples. This is typical hemangioma. This is focal nodular hyperplasia. We see up there ROI with maximum, mean, and minimum Young's modulus elasticity values in kilopascals. This is hepatocellular carcinoma. This is cholangiocarcinoma and colorectal cancer metastasis. Basically, there you can look at cutoff values of mean tumor stiffnesses in these different types of liver focal lesions, and basically some 55% of patients have those values for benign below 14 kilopascals and malignant over 32.5 kilopascals, but 44% of patients are in the gray zone. So this is nice for research, but really in clinical practice, this is, I would say, of secondary significance. We tried to propose this liver elastography malignancy prediction score, a LEMP score with cutoff over 50 predictive for malignancy with relatively high sensitivities and specificities, but I can't say that it's really used widely. To conclude about liver, elastography continues to advance and be refined for the clinical use in liver imaging. Nowadays, shear wave elastography is mostly used for liver stiffness measurement, but there are number of unresolved issues. For breast, sonoelastography is also now established and widely used, and we really use it on a daily basis with the rationale that breast cancer is stiff while benign masses are soft, elastic, and mobile, and therefore they are differently depicted at sonoelastographic images. There are different color code maps with strain elastography. As I said already, soft lesions are reddish and hard lesions dark blue. It's opposite in shear wave, where there are red hard lesions, cancers are reddish, and soft lesions are dark blue. So it's opposite, although there are now some high-end systems, like for instance Logic 10, where you can change this and you can also have in strain elastography depiction of hard lesions of cancers as red. So you should know which color scales you are using. In strain elastography, you acquire ultrasound image before and after compression with transducer, with probe, and then scanner software enables accurate measurement of tissue distortion during ultrasound beam propagation. Elastogram is superimposed over the B mode image in different colors. Red, as I said, is soft and with elastic components. Blue lesions are stiff with reduced elasticity. Some manufacturers require less compression, others require quite considerable compression and release. So again, technique varies depending on scanner. And mostly rigid tissues are blue, dark, like this invasive ductal cancer. You see here B mode and elastographic image. And soft tissues are bright reddish green. This lesion on B mode is not so clearly benign, but it was clearly fibroadenoma here on this strain elastographic image. How to interpret strain elastography? Most commonly, we use 5 points visual scale elasticity score described by Tsukuba. Japanese were the first to have it in Hitachi, and then they created this score, which is widely used. You can also use elasticity index and ratio of the stiffness of the lesion and fat, so-called lesion to fat stiffness ratio, AI strain ratio. So basically this Tsukuba elasticity score is relatively simple. If lesion is completely green, it's soft. It's equivocal if it's soft and hard. Then, score 2 is that it's mostly soft and greenish. Score 3 is equivocal. And then scores 4 and 5 are positive when lesions are hard, dark. Score 4 is that lesion is same size as elastogram, and what is certainly cancer is that you have lesion which is larger on elastogram than on V mode and stiff. So these are some examples. This is an entire lesion which is green. This was fibroadenoma, although not so typical on V mode image. This is another fibroadenoma. This is Hitachi now. The previous was GE, so they look different. This is all the machine, but you see here, well, these are different. There are some darker spots here, but majority of the lesion is greenish. It was also fibroadenoma. This was also fibroadenoma, but this is score 3, equivocal. You have roughly the same amount of green of hard and soft parts. And then this is definitely score 5. This is B mode image of this vertically oriented, very irregular hypoechoic lesion, which is larger on elastogram than on B mode and apparently very dark. So this is score 5 Tsukuba. Challenges for sonar elastography is to standardize color display across different ultrasound systems and to assess the correlation between the tissue stiffness and prognostic factors of breast cancers is also not easy. Also to decrease intra-observer variability and increase reliability of elastography to follow up probably benign lesions. Now, shear wave elastography generates, captures, and quantifies velocity of the shear wave and enables quantitative analysis by producing real-time quantitative color-coded map of local tissue elasticity. It's therefore quantitative, it's much more reproducible than strain, and it has very high spatial resolution. Again, we can measure elasticity in kilopascals. The harder the values, the higher is the likelihood that lesion is malignant. So positive predictive value for malignancy is going up as the lesions are stiffer, and stiff lesions are reddish in shear wave elastography. We should keep probe still with no pressure applied. This is important. Otherwise, you can have falsely stiff area. If you press it too much, you need to allow image to build up over some 10 seconds. Then you obtain 3 acquisitions per lesion to reduce variability. You keep region of interest small. As you see here, we usually keep it 2 millimeters. And measure the stiffest area to quantify stiffness in kilopascals. And we compare it with another region of interest we put in fat, and then get this ratio. Many breast cancers are not uniformly stiff, but have a halo of peritumoral stromal stiffness. And also it's important that the fat layer is displaced sufficiently blue and not orange or red. This means that the amount of compression was not too high and you don't have artifacts. So this is well done. Unlike this is artifact too much compression. So if compression is applied, the stiffness of lesion and surrounding tissue significantly increases. So while this is okay, because we see that we don't have this excessive color here in front. So optimal scanning technique is crucial. This is how most cancers look. Many cancers are not uniformly stiff, but you see this halo of peritumoral stromal stiffness. So blue cancers with this ring of high shear waves surrounding tumors. This is typical. And by the way, you measure here, you see that this is 145 kilopascals, while elasticity of fat is only 14, so the ratio is over 11 times. So this is clearly cancer. Benign lesions don't look like this, but this is typically how benign lesions look. This is fibroadenoma that is totally elastic, soft. This is another larger fibroadenoma that is soft. And this is ductal cancer in situ with corresponding non-mass enhancement on post-contrast T1 subtraction image after injecting gadolinium. And we see here that milk ducts are distended in this area that is corresponding to non-mass enhancement on MRI. And it is little stiffer, which is not common in DCIS. Many DCIS lesions actually are not stiff. But this is a very small invasive cancer, vertically oriented, irregular, which is very stiff on shear wave elastography. Again, you see here 220 kilopascals and a huge increase compared to surrounding tissues. Stiffness, interestingly, of triple negative breast cancers is lower compared to non-triple negative invasive cancers, but still it is, of course, higher than in benign lesions, so it's not so important. Many initial papers, some came from United Kingdom by Cosgrove, by Evans, and also by Wendy Burke from United States. What is the clinical utility of shear wave elastography in breast? And this is well known now, that addition of maximum elasticity value to Beirat's score maintains the sensitivity of ultrasound exam and increases its specificity by some 8% in initial papers, reducing the rate of negative biopsies. It also maintains its very high negative predictive value and increases its positive predictive value by more than 5%. Many papers were done to correlate tumor size and mean stiffness. It was shown that mean stiffness depends also on the size of lesion. Smaller tumors are less stiff than higher tumors, and of course, invasive cancers have much higher grades of invasive cancers are also somewhat stiffer. But initial papers were done using Explorer with upper value of the highest value of 180 kilopascals. Now, for last 6 or 7 years, we have scanners where you can measure 300 kilopascals, so quite high, much higher stiffnesses than on initial machines. Basically, soft cancers were more likely to be, if we correlate stiffness and histological grade of breast cancer, soft cancers were more likely to be low grade, tubular, and mammography screen detected. High histologic grade large cancers with lymph node involvement and vascular invasion were associated with high mean stiffness values. So there are this also, as I said, the large variation was found in stiffness with different size cancers, which indicates that intrinsic tumor biologic factors are causing variation in tumoral and peritumoral stiffness. There are some examples of false negative, like this case of large malignant tumor, which is soft. This was breast implant associated anaplastic large cell lymphoma. We didn't see many, I have to say, but this is very good example, very large hypervascular tumor on color Doppler, totally soft on shear wave elastography. So it's hypervascular, soft, malignant, but this is typical for lymphoma. This is another very rare case that we had of large malignant tumor that is mostly soft. Another hypervascular tumor, very strange, in 14 months from normal breast to this lesion, and we spotted it on mammography. This was actually plasmacytoma metastasis in the breast, quite rare, and it was totally soft, as you see here, although it has BI-RADS 5 features. There are other examples like this of stiff fibroadenoma. So these are false positive findings. This was fibroadenoma, a biopsy proven, but some small numbers, maybe 3 or 4%, are stiff. So regarding the short-term follow-up to routine follow-up, we can downgrade BI-RADS 3 lesions to BI-RADS 2 in masses with very soft elasticity, so Tsukuba score 1 on strain elastography or on shear wave elastography if you have very low maximum elasticity below 20 kilopascals. So this is an example of downgrading BI-RADS 3 lesion to BI-RADS 2 after doing shear wave elastography with very, very low kilopascal values. We can also downgrade BI-RADS 4A to BI-RADS 3. If you want to really avoid false negative, then you should use only score 1 Tsukuba and maximum elasticity color of dark blue or below 30 kilopascals on shear wave elastography. We can also upgrade BI-RADS 3 to BI-RADS 4 if there is hard elasticity on strain, Tsukuba score 4 or 5, or if maximum elasticity color is red or over 160 kilopascals. But when we are assessing small lesions, softness shouldn't prevent you from biopsying suspicious lesion. This is an example of how hard elasticity can increase suspicion of malignancy. This was young girl, actually daughter of my friends, only 25, with this lesion that looked initially maybe benign on a first glance, but it wasn't totally regular, very stiff on elastography. It was hair positive grade 3 cancer. So certainly breast masses that demonstrate equivocal elastographic results should be managed primarily according to their B-mode features. There are also there is also some usefulness when we compare This is reconstructed breast with myocutaneous flaps, and you see here this very stiff lesion, so that looks also suspicious on B mode. This was recurrence in myocutaneous flap. Stiffer lesions should be considered suspicious on second look ultrasound in postoperative breast, and shear wave elastography can be a helpful tool in identifying malignant lesions, especially if this is related to restricted diffusion on MRI scans. So the take-home message for breast is that elastography increases specificity and positive predictive value of B-mode ultrasound. As I said, it can downgrade BI-RADS 4A lesion and upgrade BI-RADS 3 lesions and enables more accurate use of core biopsy. More than 90% of cancers have mean stiffness over 50 kilopascals, but soft invasive cancers are frequently small, low-grade, and screen detected. And clinical management of a lesion should be based on its most suspicious grayscale features in correlation with color Doppler and elastography, and highly suspicious lesion on B mode should be biopsied regardless of its color Doppler or elastographic appearance. And for the last few minutes, just a few words about vascular ultrasound. In the era of CT angiography and MR angiography, we often tend to underestimate value of ultrasound. We get excellent images, of course, with CTA, with MRA. Vascular surgeons love it. But basically, there is, of course, the issue of contrast media administration, price, radiation doses, and so on, especially in younger patients. And basically, color duplex Doppler ultrasound has very high diagnostic accuracy for most applications comparable to CTA and MRA, especially when we speak about peripheral arterial disease. It provides hemodynamic and not only morphologic information. It's cheap, widely available. There is no ionizing radiation, no contrast media, but it is time consuming and not as fancy, of course, as MRA and CTA. But we have, like you in United Kingdom, national healthcare system where basically reimbursement is not based on, hospitals are not, or our salaries do not depend on volume of exams or whether you are doing highly paid exams or ultrasound, which is less paid. So I think in this setting, it's probably easier somehow to tailor and use some real imaging referral guidelines and not look in primarily into financial side of exams that we that are indicated. So B-mode ultrasound certainly enables evaluation of anatomy and vessel wall. It detects early atherosclerotic changes, intima media thickening, plaque calcifications, and allows detection of stenosis and occlusions. But if we use only B-mode ultrasound, the overestimation of degrees of stenosis is more likely than underestimation. So using color Doppler, we get fast visualization of vessel to be examined, and it demonstrates fast hemodynamic changes, also where velocity increase occurs due to desaliasing, but underestimation of disease is likely if only color is used. So for the precise assessment of hemodynamic disturbances, we need to perform spectral frequency analysis, and we of course have two types, low resistance waveforms like we see in kidneys, in liver, in brain, where there is high diastolic flow due to low resistance beds. And then we have those triphasic spectra with high resistance and retrograde diastolic flow because of high peripheral resistance. Now I would just concentrate a little bit on peripheral arterial disease, which is very widespread, but only minor part of patients who do have peripheral arterial disease require intervention, either endovascular or surgical. These are those patients who have worsening intermittent claudications, and only this group needs actually advanced imaging, be it ultrasound, angiography, MR angio, CT angio. And when we compare duplex ultrasound to CT angio and MR angio already long ago, this was published in British Medical Journal, we see that basically ultrasound does quite well. It's a little bit, of course, inferior to MR angio, but basically it's very easy to perform, to look at flow waveforms and orient yourself very fast in cases of arterial occlusions or hemodynamically significant stenosis. You can quickly assess where the level is, where pathology is, by looking at normal spectra proximally, and then distal from the pathology you see those parvus, tardus, post-stenotic spectra. So changes in flow waveforms indicate levels of diseases. We need to know well what is the normal, what are the normal spectra and what is the appearance of changed spectra, and we grade stenosis. This was described long ago, more than 30 years ago, and is very valid. There are certain levels where we look at 30, below 30, 30 to 50, 50 to 75% degree of diameter stenosis, and over 75, and those velocity ratios at the site of stenosis of peak systolic velocity compared to previous segments is the most important to grade it. It correlates very well with angiographic assessment. So what we get with ultrasound in real time, provided that we do technically correct examination with steering beam and angle correction, is that we can really quantify hemodynamic disturbance. In digital angiography, we get only morphologic image. Of course, there were even some groups when I was in the United States that were doing some endovascular interventions in peripheral arteries exclusively under ultrasound guidance, but certainly now this is an image of external iliac artery stenosis with very high velocities, with aliasing. You see that the upper part of spectrum is being put down because of this Nyquist Nyquist threshold, and you cannot increase pulse repetition frequency enough to capture these very high velocities. This indicates very high velocity, and distally you have post-stenotic spectra. So now more than 95% of patients are referred for endovascular procedures based on duplex ultrasound findings. And we were the first hospital in Croatia that we created interventional outpatient clinic, basically, where all the patients come before the procedure and then also after the endovascular treatment to follow up, where there is, of course, ultrasound machine, and they are examined by interventional radiologists who did the procedure, and it works very well. This is also good that patients are aware that basically interventional radiologists did these endovascular procedures and not vascular surgeons, where usually patients have beds and where they stay overnight. So we have these one-day clinics now where some of these interventions are done actually only in one day. So this is easy to look to assess with ultrasound the degree of stenosis by looking at velocities at the site of stenosis and distally. So combination of monophasic flow and peak velocity is highly predictive and specific to severe iliac disease and iliac occlusion are here or here in cases of severe superficial femoral artery stenosis. In pre-stenotic part of artery, you have those pre-occlusive spectra with very high resistance. So by looking at spectra just at one side in artery, we can deduce what is happening distally and proximally, not only at the site of stenosis. So even task classification, transatlantic inter-society consensus for grading stenotic occlusive lesions can be assessed by ultrasound. Also, it's good to see in case of occlusion like this, which we see with power Doppler, that almost 3 centimeters of superficial femoral artery is occluded, that you assess what is the echogenicity of this occluded segment of artery, because if it's hypoechoic like here, it's highly likely that you will be able to pass this occlusion with guide wire and do the endovascular recanalization through normal lumen, and not while if it is very calcified and hyperechoic, then the likelihood that you will go subintimally is much higher. So this is very good for planning of endovascular procedure. And just to show for the end some examples, this was a male patient, 70 years old, who had paresthesia in his left hand, weak pulse, and significant right to left pressure difference. And you could immediately clinically suspect that he has subclavian steal syndrome, but he doesn't. This is normal common carotid artery. This is his left vertebral artery, which is normal direction of flow and normal morphology of spectra, normal velocity. So he doesn't have subclavian artery stenosis. Interestingly, this is when we looked distally at axillary artery, high velocities, 4 meters per second. This is power Doppler. We did CT angiography. This was a gentleman who was carrying his wife, who was in wheelchair, to second floor. They didn't have elevator, and there was a repetitive compression of this axillary, of this part of the arm, and this was actually stenosis due to repetitive compression, external force that was severe, and I somehow managed to pass through this with a very with a guide wire and only 2.5 millimeter long balloon. Only PTA was performed, and then you could see immediately post PTA good result after recanalization at the site of PTA. So there was previously, if you remember, 4 meters per second was peak systolic velocity. Now it's normal, and also distally we can follow in ulnar artery, in radial artery, normal spectra, and we followed this gentleman for many years. This is also a gentleman who had 77 years, but he was in excellent clinical shape, and this was actually incidentally found on ultrasound, and then CTA was done in another city. This huge aneurysm of actually external iliac artery. Also note that internal iliac artery originates within this aneurysm. There was a severe kinking. It was length of 14 centimeters and 8 centimeters in diameter, high risk of rupture, and very it's not convenient site for vascular surgeons to operate. So in a hybrid suite, we managed to go with crossover technique from the other side, and first embolized with 10 coils left internal iliac artery so that there is no refilling of aneurysm. And then vascular surgeons in hybrid suite performed arteriotomy of left common femoral artery, and we placed extension of stent graft forever, which was 18 centimeters long and 1.8 centimeters wide. And therefore, with this extension of stent graft, we excluded this aneurysm from circulation. These are coils in occluded internal iliac arteries. So this is now patent aneurysm. This is CT angio, where you see that there is no endoleak. These are artifacts from coils that occluded internal iliac artery, but then you follow this patient with color Doppler or power Doppler. You don't need, he's 77, you don't need to inject a large doses of iodine contrast media in this older gentleman who of course had some hypertension as well. So ultrasound is excellent method then to follow up these patients permanently, and we did follow him up. He lived more than 10 years after it. So duplex ultrasound can be useful to select candidates for surgical bypass and also select sites of surgical anastomosis. It's recommended for routine surveillance after some bypasses, although it did change recently that it's not so useful, so I won't go too much into it, but you see these bypass grafts very easily, especially using extended field of view or panoramic view, because these grafts are very superficial. These are usually reverse vein grafts like this, these bypasses, and then you look at these grafts, proximal and distal anastomosis. If you have stenosis, again, high velocity at the site of stenosis, you can have vein graft stenosis. This is just an example. This was the bypass. Task D, occlusion of distal superficial femoral artery and left popliteal artery. Femorocrural bypass was put here 10 months ago, and then patients had symptoms of acute ischemia. And there was occlusion of femorocrural bypass. This is the origin of the bypass. We managed to go with crossover technique into the bypass and injected thrombolytic agent. You see here how it was recanalized, and now also distal anastomosis is well seen and distal arteries. And then, of course, you again follow up these patients with only ultrasound. So this is successful thrombolysis, and we use now exclusively ultrasound in follow-up of these patients and diagnosis of reocclusion. And because it's not good to give a lot of contrast in these patients, this is also distally popliteal artery and femoral and distal arteries, peroneal artery, and dorsal arteria dorsalis pedis, so all the distal arteries were patent. So to conclude, ultrasound is very useful for diagnosis, for selection of patients, for endovascular treatment, for bypass surgery, and for follow-up after endovascular treatment and surgical treatment. And just these are last slides for type 2 endoleaks after EVAR procedures. This is relatively common complication. CT angiography is routinely used for follow-up, but actually Vinizio Napoli from Pisa was the first to depict that it's better to depict with contrast-enhanced ultrasound those endoleaks. We are now using it regularly. We do quite a lot of EVAR procedures and basically follow it with Zeus now also, and really do see endoleaks, like in this case with Zeus, where you don't see it on CT angiography at all. So this is quite good. So this was in some 45 minutes about different applications of ultrasound. I hope that it wasn't too boring, but I selected ultrasound because, as I said, I think that this is one of the major differences in the way radiology is practiced. I have to say that we are very proud of national healthcare system like you are in United Kingdom, but there are of course problems because also the costs are increasing, and this is always a problem, and hospitals are all bankrupt. And what we are seeing now, which I don't like too much, is that there is some kind of turn towards a privatization of medical services, and there are a lot of arguments in this. Many former communist countries lost good healthcare systems, but I would say that of EU members, Slovenia and us are still doing relatively well, and probably Slovakia, but I hope that it will not deteriorate further. So that would be basically all.